Yes, at the back. Great. Thank you, Kamlesh. Thank you particularly, Bansi, for the invitation to make my first visit to your beautiful country, India, and to talk about the impact of diabetes prevention on cardiovascular disease, and in particular focusing on metformin. So if you want to reduce cardiovascular disease relating to diabetes and metformin, you can do that. Thank you. You could do that by focusing at one end of the disease trajectory, where people have got existing cardiovascular disease or they're at high risk. Or, as Yajnik suggested we do this morning, you could go further upstream and target dysglycemia earlier in the disease trajectory. And I'll give you a spoiler alert that one of my main conclusions is that the quantity and quality of the evidence diminishes the further upstream that you go. So some context, the association between hyperglycemia, in this case glycated hemoglobin, and cardiovascular disease is linear. So even below the somewhat arbitrary diagnostic threshold for diabetes, there is no threshold for cardiovascular disease in HbA1c, and so it's reasonable to assume that interventions to lower glycemia would lower your risk of cardiovascular disease across the whole trajectory. So let's look at some data, mainly from trials and meta-analyses. So first thing I want to provide some additional context is that, as the CENO trial demonstrated, and you've seen this slide earlier, among patients with type 2 diabetes and microalbuminuria, intensive treatment of multiple risk factors halved risk of CVD and premature mortality over 8 and 13 years respectively. So this reminds us that actually you get a bigger bang for your buck by treating blood pressure and cholesterol rather than trying to lower glucose. So what about the prevention of diabetes among those at high risk? So several studies have shown that diabetes is preventable or can be delayed. This was the Finnish diabetes prevention program. And it can be prevented or delayed if you take people with impaired glucose tolerance and you allocate them to intensive lifestyle approaches targeting diet and physical activity. The behavioural interventions have a sustained or legacy effect beyond the end of the active intervention period, which in the case of the Finnish study was 4 years. So did the prevention of diabetes through lifestyle interventions then result in fewer cardiovascular events? Well, over a 10-year post-trial monitoring period in the Finnish study, the Finns followed up about 97% of participants, and the intensive behavioural intervention was not associated with a reduction in cardiovascular risk, albeit the participants in the intervention group did have a modelled cardiovascular risk that was equivalent to the background normoglycemic population. However, in the 30-year follow-up of the DASG Chinese cluster randomised diabetes prevention trial, in which people were allocated to diet, physical activity, or diet plus physical activity for around 6 years, there was a significant reduction in cardiovascular disease and a number needed to treat of only 9, with larger effects among women than men. So as well as lifestyle, it is possible to prevent diabetes through the use of medication among people with IFG or IGT. Now, by definition, any drug that lowers glucose will reduce diabetes incidence because diabetes incidence is defined by glucose. So participants are effectively taking a diabetes treatment that lowers glucose to prevent the onset of diabetes and the need for diabetes treatment to lower glucose. So it's philosophically challenging. Nevertheless, the question is whether the use of medication to prevent diabetes has a sustained or legacy effect, and whether it reduces cardiovascular risk. So for rosiglitazone, the reduction in diabetes incidence disappears the moment that the medication has stopped. Furthermore, if you believe Steve Nissen's meta-analysis, the rosiglitazone actually increases the thing we're trying to prevent by preventing diabetes. In other words, it might increase cardiovascular risk. So what about metformin? So its history is linked to Galiga officinalis, or goat's rue, which is a hardy perennial which blooms in summer. It was a traditional herbal medicine in Europe, and it was found to be rich in guanidine, which in 1918 was shown to lower blood glucose. But it was discontinued due to toxicity and the increased availability of insulin after Banting, a family doctor in Canada, discovered it. Now, metformin was rediscovered in the search for anti-malarial agents in the 1940s. And during clinical tests, it proved to be useful to treat both influenza and lowering glucose. So this property was pursued by a French physician called Jean Stern, who first reported the use of metformin to treat diabetes in 1957. But metformin received limited attention as it was less potent than other glucose-lowering drugs, such as fenformin, and it also was associated with fenformin's adverse effects. So fenformin tended to cause lactic acidosis, and metformin got labeled with that risk and so was dropped. The ability of metformin to counter insulin resistance and address adult onset hyperglycemia without causing hypoglycemia gradually gathered credence in Europe, and so metformin started to be increasingly used. It was finally reintroduced into the USA in 1995, so they took a little while to catch up. Long-term cardiovascular benefits of metformin were demonstrated in the UK PBS trial in 1998, providing a rationale to adopt metformin as initial therapy. And 60 years after its introduction to treat diabetes, metformin has become the most prescribed glucose-lowering drug in the world, with the potential for further therapeutic applications, such as in reducing cancer recurrence. It has multiple mechanisms of action, and I've listed some on there. And for some of those letters, I even know what they stand for. So, what about the Indian diabetes prevention program, which you'll know better than me? People were allocated to metformin 250 milligrams twice a day, as well as the lifestyle arms, and that reduced incidence by 26% among 531 people with IGT, based on 2 oral glucose tolerance tests. So the metformin was similar to the lifestyle intervention. And the trial had 95% follow-up with 6-monthly OGTT, so robust outcome assessment. However, the trial was clearly too small to demonstrate an effect on cardiovascular events, although it's notable that there were no cardiovascular events in the metformin arm. So what about in the US, the diabetes prevention program? Over 3,000 people with both IGT and IFG were allocated to placebo, lifestyle, or metformin 850 milligrams twice a day. And diabetes was diagnosed by annual oral glucose tolerance test and semi-annual fasting glucose tests. And it required confirmation by a second test. So metformin reduced diabetes incidence by 31%, which is an NNT of 14 over 3 years, and was described as cost-saving in the health economic analysis. So unlike rosiglitazone, both lifestyle and metformin appear to have legacy effects in terms of prevention of diabetes. And that was in spite of the lifestyle intervention being offered to the other groups at the end of the initial trial period, and also in spite of a degree of crossover of metformin that I will come back to later. So the question is, does metformin reduce cardiovascular disease among patients with diabetes and among patients with people with so-called pre-diabetes? Well, there have been a number of trials in people with diabetes, and also in meta-analyses of these trials. And these trials and meta-analyses differ in their patient inclusion criteria, in their comparison groups, in their sample sizes, and in their duration of follow-up. The trials are very different to the more recent cardiovascular endpoint trials of glucose-lowering drugs. And for many trials, cardiovascular disease endpoints were actually reported as adverse events rather than the primary outcome of the study. Most of the studies didn't have a placebo group. And unsurprisingly, the meta-analysis is quite dominated by the UK PDS trial. So I'm quickly going to take you through the examples of the meta-analyses in date order. So Selvin reported a significant 26% reduction in cardiovascular disease mortality and a non-significant 15% reduction in cardiovascular disease morbidity of the use of metformin in people with diabetes. Lamana reported a non-significant 6.3% reduction in cardiovascular events due to metformin. Busagian reported a non-significant 10% reduction in risk of myocardial infarction. We reported a non-significant 11% reduction in risk of myocardial infarction in people with diabetes treated with metformin. And in an update of Lamana's earlier review for the Italian National Treatment Guidelines, Monami reported a 48% reduction in cardiovascular events and a non-significant 20% reduction in all-cause mortality. So I will leave the final word on this section with the most recent report from the UK PDS, which isn't included in any of the meta-analyses, and shows a sustained 31% reduction in risk of myocardial infarction associated with a 20-year period of intensive treatment with metformin compared to less intensive treatment with diet. So I think the evidence among patients with diabetes is pretty clear that metformin reduces cardiovascular risk, and among people with IGT, metformin reduces diabetes incidence. The key uncertainty is whether metformin reduces cardiovascular events among people with IGT and among people with normoglycemia. So should metformin be added to the water supply, much like people say statins should? Well, after 3 years of 850 milligrams metformin versus placebo in the US Diabetes Prevention Program, there was no effect on cardiovascular outcomes. The Diabetes Prevention Program observational study featured unmasking. The lifestyle intervention was offered to the other groups in an abbreviated form, and metformin was offered in an unmasked way to the other groups. So all groups had intensive treatment of cholesterol and blood pressure, and much more intensive than compared with the UK PDS. 70% of participants took at least 80% of the pills assigned, but this fell to only 49% over the whole of the observation follow-up period. So by the end of the DPOS, 33% of the placebo and 27% of the lifestyle intervention groups were treated with metformin by their healthcare providers. But there was still some degree of differentiation in the trial. So the metformin arm had 10.7 metformin years. The placebo group had 2.3 metformin years, and the lifestyle intervention group had 1.7 metformin years. So much fewer than might have been originally intended. And as I mentioned earlier, the metformin trials are different from the more recent cardiovascular endpoint trials. Metformin is, of course, off patent and the recommended first-line diabetes treatment worldwide. So it's a real challenge to try and set up a cardiovascular endpoint trial for people who haven't got diabetes, where the key uncertainty lies. So in the absence of a metformin trial among people without diabetes, one can instead look at the effects of metformin on cardiovascular risk markers, such as carotid intermediate thickness and carotid plaque score. And that's what David Priest from Oxford, which is a small university to the west of Cambridge that you may be familiar with. He did this in the CAMERA trial among people with established coronary heart disease, but no diabetes. And in spite of the reduction in weight and HbA1c, metformin was not associated with a reduction in these carotid outcomes. So in the absence of a large randomized cardiovascular endpoint trial among people without diabetes, one can resort to Mendelian randomization studies. And you will recall the list of metformin targets that I showed you on one of the earlier slides. And in this study, a genetically proxied perturbation of metformin targets equal to around 1 standard deviation unit lowering of HbA1c, that was associated with a 37.8% lower risk of coronary artery disease. So the Mendelian randomization fans would argue that it looks like metformin would reduce coronary artery disease in people who haven't got diabetes. We did try and do a trial of metformin in people with non-diabetic hyperglycemia, and Kamlesh was one of the investigators. We completed the feasibility study, and it was going to have a cancer and cardiovascular endpoint, 24,000 people, and we were only asking for around £13 million to do this trial, which would cost a drug company more like 500 million. But unfortunately, the funders wouldn't give us the money. One thing that we did note was that metformin was associated with a reduction in B12, which one should bear in mind when prescribing a preventive drug to people who haven't got a disease. Fortunately, the American funders in the Veterans Administration system were more enlightened, and a metformin cardiovascular endpoint trial called IMPACT is underway, albeit it's different from GLINT in that participants have established cardiovascular disease, which will increase the event rate and mean they can have a smaller sample size, and they also have pre-diabetes. It's due to report in 2029. So to summarize, type 2 diabetes can be cost-effectively prevented by lifestyle interventions and by metformin in people with IGT. The effects of lifestyle interventions and metformin on diabetes incidence were sustained and are associated with a range of improved outcomes that I didn't cover today because my focus was cardiovascular disease. The long-term impacts of diabetes prevention by lifestyle change, the long-term impact on cardiovascular disease, were seen in China, where perhaps people adhered to the lifestyle intervention better than in America or Finland, but they weren't seen in the other diabetes prevention programs. Metformin is the recommended first-line treatment for type 2 diabetes, and it's licensed worldwide for the treatment of diabetes and, in some countries, pre-diabetes. The impact of metformin on cardiovascular disease risk among people without diabetes does remain uncertain, but evidence from observational studies and from Mendelian randomization studies would suggest that it would be an effective treatment. Alongside treatment of blood pressure and lipids, individuals with pre-diabetes should be offered lifestyle interventions, and if they're unsuccessful, they should be supplemented by use of metformin. But to reduce the burden of cardiovascular disease related to hyperglycemia, a complementary approach is needed to shift the population distribution of underlying determinants of hyperglycemia. And my last comment refers to the prevention paradox. While those at the extreme end of the distribution for cholesterol, blood pressure, and glucose are at highest risk, there are few of them. Consequently, the majority of heart attacks occur among people at moderate risk with moderately elevated blood pressure, cholesterol, and glucose. So if we want to reduce the population burden of cardiovascular disease, the distribution needs to be shifted to the left. And this phenomenon was described by the late Geoffrey Rose. Unfortunately, the distribution in most of the world is moving to the right. So this slide shows rural and urban Cameroonians and Jamaicans in Jamaica and Jamaicans in Manchester. And you can see that the fasting plasma glucose is shifting in the wrong direction. So if we want to do something about that, then we need to target the underlying individual and collective level influences on hyperglycemia. And we need to do that at a generational level, as we heard this morning, because leaving it until people are at high risk is leaving it too late. So thank you very much for your attention, and I look forward to discussing your questions.